All right, it looks like our attendee list is continually increasing, so we'll give it a couple more minutes to let everyone settle in.
Perfect.
We'll give it another few seconds before we kick off. Looks like we still have attendees coming in.
Okay.
Okay, as we have more attendees coming in, I'll just start kicking off by doing our brief introduction. So welcome everyone. Thank you for joining us today. My name is Larnie Cayetano. I'm the marketing manager here at Lumenis Vision. Lumenis Vision, the proud inventor of IPL, SLT, and the first argon photocoagulator, is renowned for technological breakthroughs in ophthalmic light-based devices with a long list of industry gold standards. With over 50 years of presence in the eye care industry, Lumenis Vision has focused on providing eye care providers with innovative therapies to preserve and improve the sight of patients worldwide. In collaboration with the American Society of Optometric Surgeons, we are bringing you a webinar series focused on anterior segment lasers and IPL technology. Joining us today is Dr. Selina McGee of Precision Vision in Edmond, Oklahoma. She's a nationally recognized expert on IPL and other aesthetics procedure. She will kick off our collaborative webinar series with a talk on IPL, MGD, and other fun acronyms. With just a little housekeeping before we get started. If you have any questions during the presentation, please type them into the questions box in your panel. We will answer the questions in the end of the presentation. Now, without further ado, we'll turn the time over to Dr. McGee.
Perfect. Thank you. Thanks, guys, for joining us. This is going to be fun. So, as she said, we are going to talk about IPL, MGD, and other fun acronyms. And hopefully, you guys aren't zoomed out, webinared out. We will make it as interactive as possible. So, put questions in that notes box. I've got time at the end built in so that we can talk about it. So, all burning questions go in there for sure. And I someday, hopefully soon, wish to do this in person with you guys, but thanks to ASOS for sponsoring this so that we can continue to learn and be colleagues together. So when I talk about dry eye and when I talk about why I do the things that I do in my clinic, so as she said, I'm in private practice and I've built a dry eye clinic within my private practice. And I always think about, you know, we go to all of these sessions and we learn the what and the how, but sometimes we really need to dig a little deeper and go, okay, why am I really doing this? But my dry eye patients are the most loyal and they really need help. A lot of times they've been shuffled around from doctor to doctor, desperately trying to find someone to help them. And so I have found this patient population to be especially challenging because this is not an easy disease, right? But they are, again, you know, my biggest fans and they'll follow us anywhere. And so really think about what you're really trying to do and why, and make sure that you communicate that to your team around you so that they can help you with these processes as you go and you build this. And we're going to dive into IPL, but I also want to talk about how to make this a success just from a practice standpoint, and how you talk to patients, how you tell your staff this. And sometimes we have to think about changing our mindset. So 3.8 million cataract surgeries were performed last year in the US. And then 3 million glaucoma patients, only about 1.5 million of those are being treated, because the other 1.5 million don't know that they have it. But when you look at how many dry eye patients there are in the US, 40 million, depending on which survey that you look at, do you have systems in place to uncover these types of patients? And so I always go back to Melton Hum taught me this years ago. I walk into the exam room with the mindset of, I need you to prove to me that you don't have dry eye and you don't have MGD. Just like I proved to myself that my patient doesn't have glaucoma by checking their eye pressure and looking at their OCT and looking at their optic nerves. And so I want you to change your mindset, and I want you to start to uncover these patients if you're not already doing that. And it can be very simple. This does not have to wreck your clinic. You can do a very simple questionnaire, just ask a few questions. You can use, point of care testing. Just have systems in place to uncover these and measure it and track it. If you see 10 patients in the morning, if you look at the numbers, you should have 3 of those that got diagnosed and you're actively treating. If those numbers are really small, then, look at why you're not uncovering those. And so, do this as a step-by-step process, but really look at changing your mindset and proving to yourself that these patients don't have it. So are your patients well controlled? That's another question that we actually also ask, our glaucoma patients. Do you wish that you sometimes had more options to treat your dry eye patients and your patients that suffer with MGD? Do you even understand how to incorporate all your options? When I started practicing 18 years ago now, we didn't really have a lot of options. And now we are sometimes overwhelmed with options, and I don't know where this fits in with my toolbox. I have lots of tools, but I don't know the steps. So we're going to walk through that. And dry eye is a vision-based disease. It touches every single patient. I don't care if you have a private practice with an optical. If you don't do a good job of uncovering this, it will affect your optical, because you're going to have to do glasses redos. If you treat glaucoma patients, 60% of those people have dry eye. If you see patients with cataract surgery and you refer those patients and you co-manage, it affects those. It affects all of your refractive surgery patients. Every single patient in your clinic, you need to be able to have this conversation with. And it is a vision-based disease. And Mother Nature has devised this system really well, but guess what came out in 2007? This little nice computer that we all carry around with us. And now, even more so, what we're seeing, because people are at home, that our eyes are not meant to look at devices all day long. So our goal at the end of anything, and I take this back to the TFOS DUCE 2 piece, is our end goal is to restore homeostasis. It's gotten disrupted depending on a lot of multifactorial things, but we're trying to restore homeostasis. But guess what? 86% of the time it fails. So step-by-step approach, and this is a lot of stuff on a slide, but if you start to go through these step-by-step and you have a system in place with every single patient that you do this with, then this becomes muscle memory, and it's much easier for you to uncover these patients. And I won't go through, because we've got a lot of other stuff I want to go through, but you guys will have copies of this at the end that you can review. Simplicity is the key to brilliance. So we have to ask the right questions, have a questionnaire. We look at the risk factor analysis, meaning we're looking at systemic diseases, we're looking at medications, we're looking at, does this patient have glaucoma, what are the comorbidities, and then what diagnostic tools that you use. And you do not need fancy diagnostics. I like lissamine green and fluorescein strips. That will tell you a wealth of information. If you don't have that already in your clinic, start there and then build on it from there. And then you can add point of care testing and meibography and X, Y, and Z. But you can do this really well with just fluorescein and lissamine strips. And then classify and treat and look at your DUCE 2 diagnostic algorithm. So step therapy, that's how I tell patients. We're going to start here and we're going to step it up until we get you where you're having more good days than bad days, where the bad days aren't horrible. And we're just going to step your therapy up. And most patients recognize this because they've heard of step therapy with other modalities. So patient education is really crucial. So, you know, they need to trust you from the beginning so that when you do offer more advanced and things like IPL, then it's not coming out of left field. So of course, this is the definition that came out in 2017. And I like the fact that, of course, it has multifactorial in there. The one underlying thing that it's always had was inflammation. And there's that word homeostasis again. So we're returning homeostasis to the front surface. And then there's the neurosensory component, which I think is really important. But remember, there's no silver bullet diagnostically or therapeutically for this disease. Again, this is not an easy disease to treat, but it's so worth it. And you're going to see some of my patients and how critical this is to just their everyday life. So neural pathways are critical. That lacrimal functional unit regulates our tear secretion. And so we get that feedback to the lacrimal gland that things have gone awry. Now we have fewer tears. Now we've got inflammation and, you know, a whole wealth of things that happen on that front surface. And now we've got a vicious cycle that we have to do something to interrupt that cycle. So this is the definition of MGD. It's a chronic diffuse abnormality of the Meibomian glands, and it alters, you know, tear film, symptoms of irritation, and clinically apparent inflammation, as well as ocular surface disease. So just a little bit about anatomy. Large sebaceous glands are located, of course, in the tarsal plate. There's more in our upper lid than our lower. And this is important right now for us to remember as well. A lot of our teenage patients or early 20s patients are taking Accutane, and you know that targets sebaceous glands, and so you can absolutely decimate those glands with too long of therapy. And so I have gotten to where if I have a patient that I know is going to start that regimen or is taking it, then I image them and I let the dermatologist know, hey, here's what can happen. We need to watch this really close. And so I monitor these patients monthly now, so that we know if there's going to be a problem, because I've got some patients in their, you know, mid to late 20s who have no Meibomian glands left. And it was because we think that they had a long bout with Accutane that they were on for 6 to 8 months during their teen years. So structure and function, you know, we want to look at structures. And we've just started imaging, right, only in the last 3 to 5 years. We still don't fully know completely what we're looking at. And you know, what matters and what doesn't. And so there's going to be more to tell there, but I have gotten to where I image everybody in my clinic as part of their wellness exam, just so I know that. And are they functioning? So not only are we looking at the glands, but we're pushing on them to see, do they function and what that looks like. And so structure versus function, you know, what does that also sound like? We'll get to here in a second. But examples of Meibomian gland evaluation. So when you're looking, you know, is it clear? It should look like olive oil, or is it cloudy, or does it look like toothpaste? Those are all things that we need to know. And then of course you've got end stage in that bottom right-hand corner where you've got this perfect notching, and we know those glands have been lost. And, you know, meibography has been super powerful in imaging and being able to tell the patient's story to the patient. They can see that there's a problem here, right? They can see what's normal and what's not. And they're like, what's happening here? So those conversations do become easier with meibography and being able to have that technology in your clinic. Do I think that you can't do this without it? Absolutely not. You can certainly do it just by, you know, pressing on the glands and then using your vital dyes. So what other disease do we talk about structure before function? Glaucoma, right? We talked about that. We're looking at pressure, we're looking at optic nerves and how things are functioning. And this raises the standard of care also. So, you know, we don't want to talk about this disease after we've lost 90% of your glands. We want to talk about it when there's a problem at the very first part of this disease process. So pathophysiology, you know, what happens on the front surface that starts to cause all of this? we get increased viscosity and we get hyperkeratinization. And some really key signs to look for when you're looking at the lid margin and you're looking for this disease is, lid foam is pathognomonic, obstructed glands and their orifices, lipid crusting, collarettes, telangiectatic vessels, and lid margin redness. Those are all things that you're looking for at the slit lamp when you look at lids. So I love this slide. This came from the Ocean Group in 2017. So Meibomian gland dysfunction can arise from any combo of 6 separate conditions. And here's where our other fun acronym is. So that's a lot to remember on that top part, but what's easy to remember is the bottom one. So think about it's BISTO is how we pronounce it. So bugs, meaning, bacterial burden or Demodex, enzymes, inflammatory markers, inflammation, we get stasis of the meibome. We have the temperature actually increase, which encourages more stasis, and then we have obstruction and hyperkeratinization. So that's where you get BISTO. So any one of those 6 things can cause and trigger and cause this vicious cycle for us in the MGD process and disease process. So the really cool thing about intense pulse light is when you look at those 6 pieces, what does IPL treat? So we know that it treats bacterial and Demodex load. It just so happens that the little exoskeletons of Demodex are the exact same wavelength or target as chromophores of our pigment. So they literally get barbecued. And you can see them on an electron microscope when you pulse it once. They're, it's like 1, 2, and then they go bye-bye. So they literally get barbecued. We're controlling enzymes, we're decreasing inflammation, we're improving stasis, there's some temperature regulation there, and then we're helping with obstruction and hyperkeratinization. So you can treat Meibomian gland dysfunction lots of different ways, and you can see that if you combine a medication with thermal pulsation with an omega-3, that you would hit all 6 of those. But with IPL, you're able to address all 6 of those pieces that are contributing to MGD. So diagnostic dry eye workup, this is what it could look like. A speed questionnaire. I use osmolarity and inflammatory in my clinic. I definitely always use lissamine green and fluorescein staining. Look at your tear breakup time, your tear meniscus height, and I use the Meibomian gland evaluator that you see in this picture, and then of course Meibomian gland imaging. So, again, you don't have to have even all of that, but if you have pieces of that and can build on that and build that into your clinic and start to get some success, then you can add more expensive toys, basically. Don't try to do it all at once. So this is actually in the treatment profile in the TFOS-DUCE 2. This is in step 2. So if you look at step 1, we've got, education about the disease, modify your environment. But guess what's in step 2? In-office intense pulse light therapy for MGD. That's step 2 within TFOS-DUCE 2. So let's talk about differentiation of various devices for skin. So when we announced this, and ASOS is sponsoring us, when we look at lasers and we separated out IPL, it's because it is different. This is not a laser. It's intense pulse light. It's literally filtered light. So don't get trapped into that this is a laser. It's truly filtered light. We're just utilizing certain filters to target chromophores. It's typically non-ablative, and then we'll talk a little bit about lasers and radiofrequency and ultrasound just so we can differentiate, because this originally started in dermatology. So difference between lasers and IPL sources: lasers are monochromatic, coherent, and parallel. So when you see a laser handpiece, you see a 1540 because it's monochromatic. It's utilizing one wavelength of light. Intense pulse light is non-monochromatic. So we're using multiple different wavelengths, and we're just filtering out what we want and what we don't. So IPL is, I love this picture just because it tells us where we're targeting within the dermis, within the skin. So we don't want to treat, a hair follicle because we might destroy it, right? This is actually sometimes used in clinics to remove hair. So we have to be careful where we're using this with our patients. And you can see as we, scroll over to like a CO2, which is a full invasive laser, that's literally ablating the entire top of the surface off. High risk, high reward, but you can see where the difference is, how the depth of where that is in the skin. So how it works, it's broad continuous spectrum of light. We're ranging typically between 515 and 1200 nanometers, and then we apply different filters to get our target. So think of it as reds and browns. So chromophores, melanin, and hemoglobin, that's what we're targeting. Melanin absorption is around the 400 to 700 nanometer range, and then blood absorption is between 900 and 1200. So how this all works, and we'll tie all this together, is just think about reds and browns. But we're targeting that oxyhemoglobin in the blood vessels. And what's important and what's different about Lumenis is the way that their filters work and the way their light works. And we'll dive into that a little bit deeper, but it's important how they deliver the energy. So a light is emitted through a filter, which cuts off the undesired wavelengths. And that also depends on, again, your patient, their skin typing, and what you're trying to target. So we've got filters 515 all the way up to 695. There's a vascular filter, the 755s for hair removal. There's acne filters. You need to know what your license allows in your state to be able to do this. So it is the most popular cosmetic skin procedure performed. That's how we even found out that this could be used in eye care. It's been used in derm for years and years. And Dr. Toyos was using this on cosmetic patients, and oh, by the way, treating for rosacea, and their dry eye got better. And so, like many things in medicine, it happens that we're using it somewhere else and we find a benefit for something else. But rosacea alone represents about 16 million people in the US. And, this is a skin disorder. So when you have telangiectatic vessels on the lids, that's part of their skin. And so we need to be able to treat that, and IPL will do that. So what is on label and what is off label? With the M22 on label, we're treating telangiectasias. You can do photorejuvenation, which is also what they call the photofacial, acne, rosacea, hair removal, benign lesions, more stuff that we're not really probably going to get into. And then it does treat fine lines and wrinkles in a non-ablative way. It's off-label currently in the United States for Meibomian Gland Dysfunction. It doesn't mean we cannot use it. It just means it's off-label. So historically, rosacea, let's dive into that. It's a chronic skin condition. It's classified into 4 subtypes. There's a new system that just has 2 diagnostic phenotypes. So let's look at this word, erythematous telangiectatic. I actually said that. I'm not going to say it 3 times fast. Papulopustular, phymatous, and ocular. Fixed central facial erythema. So used to we talked about those top 4, and the phymatous changes were typically rhinophyma. And as things have changed, then there's that new system. So this is a patient that has the erythematous flushing. She also has the telangiectatic vessels of rosacea. So she is one that has lost a lot of confidence, doesn't wear makeup anymore. Her eyes by 10 a.m. in the morning feel absolutely terrible. She's putting in artificial tears about every hour on the hour. Just so happens that she's one of my technicians. And we decided to treat her. This is my husband, who also has rosacea and suffered with it for 2 years. I told him repeatedly, you have rosacea, there's different things we can do to help this. And he finally went to the doctor, and he came back with his little bag of doxycycline and ivermectin, I think. And I said, what did he say? And he goes, I have rosacea. Yes. Okay. So again, when you're the home, you're never the expert. And then of course there's ocular rosacea. So let's talk about what those look like differently, because a lot of our patients will have ocular rosacea previous to developing the skin rosacea. So many times we're on the front lines and we're the ones diagnosing patients with this. And so you see on this patient all those little telangiectatic vessels crawling over that lid margin. And not to mention that she's got makeup where it shouldn't be. But those little vessels, guess what? They're leaky. They're leaking inflammation all over the front surface. So 80% of rosacea patients suffer with MGD. And presence of one of the more following primary features, they can have the flushing, they can have the non-transient erythema where it looks like acne, they can have the telangiectatic blood vessels, and then they can have the secondary features, which is, you know, the burning and the stinging, red plaques, and then they can have the ocular manifestations as well as the phymatous changes like we talked about. Most commonly it's rhinophyma. But look at this number, 20% of those patients precede facial rosacea. So again, we have to be educated about this because we might be the ones that are diagnosing the patient with this and they've never heard about it. And that in fact happens a lot of time in my clinic. And rosacea associated MGD is a worse prognosis for the patient. And so now we've got things like IPL to help us with that. So because 20% of the ocular rosacea precedes facial rosacea, you know, we talk about triggers. Spicy food, alcohol, sun, caffeine, those can all make it worse. So, you know, we talk about sunscreen, we talk about lifestyle changes and what you're eating. Different medications are, you know, Rofade, there's beta blockers, there's brimonidine, which we're all familiar with because we use it on the eyeball for glaucoma, but you can also have the topical version. We can do minocycline and low-dose doxy, ivermectin, azelaic acid, metronidazole, and isoretinoin, which is Accutane. So make sure that you're talking to your dermatologist when your patients are on Accutane, and then of course IPL. And let's talk more about that. So here's eyelids before and after photos. Dr. Perryman shared with us, new patient. She'd been, you know, had red eyes for, you know, over 2 years. RX with steroids 4 months later after her series. And I typically do a series just like she does. So I will treat patients depending on how aggressive my settings are 2 to 4 weeks apart. And we'll start with a series of 4. And then we can typically maintain that every 6 months to a year. I have a handful of patients that need it about every 4 months. And so they'll come back for that. And so the patient on the right is a patient that she actually has keratoconus, which is why you see the intacs there. And I also have her in a scleral lens. And she was really having a lot of trouble and discomfort and had tried everything. But look at all of those telangiectatic vessels that she had on her lid margin. And in the bottom picture, which was after just the 3rd treatment, how much more improved that is. And her symptoms were better. Her inflammatory was better. That was actually completely gone. And then tear osmolarity had stabilized. So not everyone is a candidate for IPL. So we have to talk about skin type. And, you know, it can be used different places on the body. Obviously, we're going to use it just around the eyes, but it can be used on the face and the neck, décolleté, hands. So let's talk about who we can do this on. It's very safely done on skin types 1, 2, and 3. So I like these pictures because it just tells us, you know, gives us a good image of what those skin types look like. I also ask the question to patients because a lot of people have done 23andMe or, you know, genetic testing, so they have some background too that helps us when we're going through their skin typing. And there's a questionnaire that you can go through this with your patient so that you're not the one that's deciding this. You and your patient together decide this based on how they answer the questions. I have treated a few type 4s very, very carefully, never treated type 5 or a type 6, because remember what our target is pigment, right? So we can't even treat anything below the surface if we've got melanin that's all absorbing the energy right on the top layer. So you're going to overtreat and cause scarring. And so starting off, you can very safely treat types 1 through 3. I would not start off with a type 4. I've only got 2 or 3 patients that I felt safe enough to do that, and we did a test right here, 1, 2, and 3, and we let that set for 48 hours before we came back and did the rest of the treatment. Patient selection, you need a fully detailed medical history. They can't have active lupus. You know, use a medical questionnaire and informed consent form. If they have any lesion that looks like it has malignant potential, absolutely do not treat that. That needs to have an excision biopsy to be before you can treat. And patients with unrealistic expectations should obviously be identified during the consultation and discouraged. And so again, we're treating MGD and dry eye. This is a tool in our journey with our dry eye patients. This is a lifetime process. So make sure your patients fully understand that you're in this journey with them. Do not treat melasma patients. You can make melasma worse. Before you treat, all makeup has to be removed. So if they have sunscreen, anything on that's got pigment, you can way over treat, and you're not going to get the result that you want because it's getting absorbed by the pigment. So skin assessment, tanning of all forms is a contraindication because you've got melanin on the front surface closer to the upper epidermis. So basically all your energy is going to be absorbed right there, creating essentially a light blocker. You can't get any deeper in the skin. You're going to over treat. And cheating the system does not work. So self-tanning lotions, again, same thing. None of that. So tan skin, you can't cheat the system and be defined by selecting a darker skin type. So if they've been in the sun, they have to reschedule. And they shouldn't be in the sun anyway because we're treating rosacea. That is a trigger that will make it worse. So sunscreen, a broad build hat, and depending on their skin type, you know, if they're a skin type 1 and they've been in the sun the weekend before, fine. But if they're a skin type 3, no. So, you know, utilize a checklist for safety. Make sure you've got all those protocols in place. I love this book by Ocul, The Checklist Manifesto. It shows how much safer you keep your patients and how much your surgical team operates better when we're all on the same page. So contraindications, treatments that cannot be attempted on patients or should not be. We talked about a dysplastic nevi, any kind of active infection. If you've got broken skin, then don't treat that area. Significant, any kind of concurrent skin condition that you're not sure what you're dealing with, active cold sores, chronic or cutaneous, viral, fungal, or bacterial diseases. And of course, we talked about exposure. And tattoos are contraindicated because remember, our target is pigment. So you can really overtreat and you can remove part of that pigment with this. So, you know, if someone's got their eyebrows tattooed on, you need to know that. Eyeliner tattoo, same thing. So be careful with patients that have tattoos. Treatment should not be attempted on patients with a history of skin cancer or any kind of precancerous lesion in the treatment area. Pre-treatment patient education, you know, talk about it. Results aren't guaranteed. This is, again, a process. And, you know, if they want, because I have an aesthetics clinic alongside with my dry eye clinic, and we talk about treating their MGD. Oh, by the way, it can also help your skin appearance if that's something that you're interested in. Just don't overpromise that. It will help fine lines, and of course, it will take off some pigment if they have some age spots that they don't like, but don't overpromise those. And adverse effects include redness, swelling, burning. Typically when patients leave, they look like they have like a sunburn or a really light sunburn, a light windburn. Multiple treatment sessions, typically 3 to 5, depending on the patient, are required for optimal results. Most of my patients get 4. And then maintenance treatments, we talked about earlier, recommended every 4 to 6 months, depending on the patient. So when I do this, we have the patients pay up front because I want them to get the full benefit of all 4 to 5 treatments. So if they're taking Accutane, they need to stop that a month before their treatment. If they're tan, of course, they're rescheduling. Don't apply, you know, makeup and lotions the day of. Make sure your technician tells the patient that before they come in. You can save yourself a lot of chair time. If they do have a history of cold sores, you can prescribe, you know, Valtrex or Famvir on the day before to help with that. And then, of course, you know, any new medications and tattoos we need to know. Procedure checklist, we've already talked about. Treatment parameters. So let's talk about what this actually looks like. So bottom right hand, those are our different filters on the M22. We've got cutoff filters, we've got pulse duration, fluence, and number of pulses. So we're going to walk through this so when you're looking at the machine, you know what to change, what you need to be looking for. And Lumenis does a fantastic job of having pre-treatments already built in for you, and that has been immensely helpful, especially when you're first starting out. So based on what we're trying to achieve, we can do single pulse, double pulse, or triple pulse, meaning that the energy is going to be the same, but it might be delivered in one pulse, but it might also be delivered in 3 different pulses, spreading out the energy. And then we've got duration, so how long the pulse is, the delay between the pulses, and then our fluence, and then we've got all the different cutoff filters. So if you want to go deeper in the tissue, then you need a higher filter. So everything under 695 wavelength is going to be blocked off. That way you can get deeper into the tissue. And depending on the rosacea, you will need to start off with treating deeper layers and then treat a superficial layer. Because if you start off treating the superficial layer, you won't get to the deeper layers because you've created all this erythema and now they're in our target. So all important things to know, not only the settings, but the correct steps and how to apply it. So pulse durations are important because we're slowly heating those vessels to coagulation. That's how they get destroyed. But we do it so slowly with this device that we're avoiding bruising. That's the downside to PDL, which is notorious for this. Patients would bruise, because it heated it so fast that the blood vessel just exploded. And then energy levels are governed by the clinical response. So when you are doing this, you're looking at how the tissue responds. You're not just, and not look at it the whole time. Do 3 pulses and three button pushes, I'll say, and then pick your glasses up and look and see what the tissue reaction looks like. You want it to be pink, like certainly, you don't want it to be bruised. You don't want it to be overdone, but you don't want it to do nothing either because you don't want to undertreat people. So a good rule of thumb is mild to moderate erythema as the treatment endpoint. That's your endpoint. You know that you are where you should be when you can see that skin is pink. So cutoff filters are selected to optimize targets of the chromophore. And again, that's going to vary by your skin type, and the machine knows this. It's going to walk you through this. And so depending on if you're targeting pigment or if you're targeting blood vessel or you're targeting oxyhemoglobin, depends on your filter. So let's talk about treatment aggressiveness. So less aggressive is a higher cutoff filter, so meaning a 695 is less aggressive than a 515. Lower fluence, of course, is less aggressive. That one's more intuitive. Higher pulses is also less aggressive. So we talked about that when you have 3 pulses, that spreads the energy out versus just a single pulse. That is a lot of energy in one single pulse. Longer delay, so if you have more time between your pulses, that's also less aggressive, right? So a 590 nanometer, everything below 590 nanometers is getting blocked. It's a triple pulse, 6 millisecond delay, 4 millisecond is how long we're taking. And so that's actually one of our settings for treating MGD. More aggressive down there, 515 nanometers, single pulse, 4 millisecond. That's actually what I use to treat an age spot. You would never want to treat a whole face with that. It's way too aggressive, but that will take off pigment beautifully. So pearls, good rule of thumb is to use mild to moderate erythema as your treatment endpoint. If you're treating pigment, if a patient has a little spot right here that they want treated, the way that you know that your clinical endpoint is when that darkens. When you hit that and you look at it, immediately it will be like a salmon, like darker color, and that's good. It's going to come to the surface. It's going to look like coffee grounds, and then it's going to slough right off. Double, triple check your settings that you want to use. So I look at all my settings. I make my technician look at my filter and the settings, and then I look at it one more time before I actually fire. So as a rule, darker skin types, of course, require cautious treatment with lower energies. And then if they have, this is really important, if they have beauty spots that they like, so I have a mole on my face on one side, I can't remember, but I like it. I don't want the pigment taken off of it. Use a white waterproof makeup pencil to cover that, because once you put ultrasound gel over the top of it, then you can't see it anymore and you might accidentally hit that. So make sure that you cover those spots up that people like so that you don't accidentally remove them when you're doing this procedure. So post-procedure, I learned this the hard way. Use your tongue depressor that you put the gel on. Use that to take all the gel back off, use it like a ice scraper, basically. It'll save you a whole bunch of Kleenexes. And then, keep that treatment area clean by gently cleansing, and then moisturizer with an emollient. Avoid direct sunlight, no sunlight. And then SPF 30 through 50 until the next session. They should be doing that anyway. No fragrance and deodorants as long as that skin is sensitive or fragile. Don't go home and do like a big, walnut face scrub, apricot face scrub, or something that's gonna like tear up your skin. Gentle is key afterwards. So pitfalls, things to do when you're first starting out. Because this hand piece it's really comfortable, but it's foreign, right? Something new and different. So you don't want to press too hard on the skin, because what happens when you press too hard? You blanch the skin, right? So you squeeze those blood vessels and there went your target. So you want it to be just perfectly tangential to your skin without pressing on it. You just need a really thin layer of gel. I used to use a ton of gel. I don't use as much gel. Make sure you're covering eyebrows and other hair-bearing areas that we're not in, unintended hair loss, especially on my dudes. If you can't see where their beard line is, have them mark it. Take off all makeup and lipstick before you start the treatment. You can over-treat and cause a burn. And, start off less aggressive. You can always get more aggressive, but you can't take stuff away. So, you can always add more, can't take away. Complications, redness, swelling of the treatment area. Typically, most patients are just going to feel like like they would if they had a mild sunburn within 48 hours. There's really no downtime to this, which is great for the patients. You can have pigmentary changes if you are really aggressive. You can get hyperpigmentation or hypopigmentation, and then other complications, blisters, redness, scarring, bruising, none of those things that we want. We don't want to do anything that would permanently change someone's appearance. So questions that I often get asked: can I treat a patient if they're on doxy? So if it's low dose doxy, yes. So photosensitivity with doxy comes with UV sunlight, right? But IPL has no UV light. So if you want to be really safe, just have them stop it 2 weeks ahead of time. Can I use topical numbing agents? So this stings is maybe an understatement. So I tell patients it's going to be like a really hot rubber band snap. And for some people, it's even more than that. For others, they're fine with it. So, but a lot of doctors ask, my patients really are uncomfortable while I'm doing this. Can't I just use a topical number? And the answer to that is no, because you've got vasoconstrictive properties in those topical numbing agents, and there goes your target. So your treatment's not going to be as effective. And, when I start off the treatment, I count to 1, 2, 3, so they know it's coming. I have little squeezy balls. And when they need a break, we take a break. And so I've never had anybody not be able to finish the treatment other than my husband, but patients, they're fine. So this is a really big question I get asked a lot. Do I need to treat lids? So let's start there. And then do I need to do expression? And I'm happy to answer more questions about this. So when I first started off, I did not treat lids. It's a little more aggressive. You need a few more little tools. And I had great results. I have never expressed a patient, and I've had great results. I now do treat lids, and I still don't express patients, and I get great results. Dr. Perryman, she does treat lids, she does not express. Dr. Adler treats lids, doesn't express. Dr. Toyos does not treat lids, and he does express. Guess what? All the patients get better. So there's no study as to date right now that tells us how to do that, but I will tell you that all of the patients, no matter which protocol they're following, they get better. And that's the really cool thing about this device. So do I do this before or after thermal pulsation? Let's say you have, LipiFlow or Tear Care or iLux, in your clinic. You know, where does this fall? How do I do this? So most patients don't always need thermal pulsation at the end, but some will. And so they'll do it at the end because you've decreased inflammation, you've, you know, made things, the environment better, and then you can do your thermal pulsation if you need to at the end. So it just depends on your clinic protocol, but I save thermal pulsation for after IPL. And I have a lot of patients that want to do radio frequency, which is, some people have heard of Paiva, or Temperature is what I have. Thermi, I think, is another one. So if I'm doing this because they want to use IPL to address their dry eye, but they also want to help fine lines and wrinkles and also get some skin tightening and lift. And so I will do IPL first and then RF afterwards. And then if they still need, like, because I do Botox in my clinic as well, if they need that, you can tack that on the very end. So you can do all three in one setting. You just have to make sure you're doing things in the correct order. Shields. So if you are going to treat lids, you absolutely have to have laser grade shields to protect the front surface of the eye and all of the inner structures. I use a 26 millimeter laser grade shield from Anthony Products. They work great. I have yet to have a patient that I could not get the 26 millimeter shield in. They come in 4 different sizes, but I bought the biggest size because I wanted the most coverage on the eyeball as possible. And then just make sure, if you're not treating lids, perfectly okay, then, you know, just use the little sticky IPL shields. Those work fantastic. I like this Innovative Optics. I have this set because I have so many patients, and you will too, that have eyelash extensions, and you cannot use the sticky shields, and they may not fully, you know, need, and it's hard, honestly, to treat some of those eyelash extensions because they're so long with treating lids. And so I like this pair of goggles from Innovative Optics because you can move that nose piece back and forth, and you can really get your hand piece in there and not bump things. They are fairly expensive, but well worth it because you can really dig into those treatments and get your energy where you want it to be without tearing off somebody's eyelash extensions. So this is what I follow when I first started, is Dr. Perryman's protocol with the M22. She's got a fantastic YouTube series called the Dry Eye Master, and I do the full face rosacea settings depending on if they have erythematous rosacea or if they have telangiectatic rosacea. And then I do Toyo settings to it's basically tragus to tragus. So we're treating V2. If you remember your trigeminal areas, so V2 runs in front of your ear, across your nose. So those I do a double pass, and then I treat lids last. And you can see my patient here that's got his laser grade corneal shields. We do lids last with the small handpiece, or with the small crystal, and same Toyo settings. And then if there's anything that I want to spot treat at the end, if they've got a telangiectatic vessel that's stubborn, or if they've got pigment, then I spot treat those at the very end. But you can see how to place your crystal on the bottom left-hand picture. So you want the most energy possible across V2. You don't want to turn your crystal where it's longitudinal to like that eye shield. You want it the way that it's directed there, because again, you want as much energy as you can get there. So this is our very first patient that we saw on the first slide, and this is when I very first started. So I wasn't treating lids back then, and she wasn't honestly super excited about me treating her eyelids, and she did fantastic without me doing that. So she's got her IPL grade shields on and her gel, and so we're gonna treat her starting in front of tragus and moving across. And I'll play it for just a minute so you guys can just see. It's honestly the brightest light known to man. Make sure that you have your goggles on that are IPL grade. And when you do this, again, make sure you're tangential to the skin. You're not pushing too hard. do, you know, two to three shots and then look at it. And you can hear that you can hear that pulse as it goes, and you're just going to work your way across. But whenever I do this, I have my goggles on, but I also close my eyes because it's so bright, the after image, I can't see what I'm doing. And so that takes a little bit of practice too, but you'll get there. But always have your goggles in place. Don't be tempted because they're filtering out those wavelengths. You can't see the skin. So you're going to stop and you're going to lift and you're going to look, and then you're going to put them back on. Don't be tempted to go without your goggles. So this is her starting off in the top picture, and then this was after just 2 treatments in the bottom, and you can see how much smoother her skin is, how much less redness she has, and her eyes felt amazing. She said, and this was the far picture on the right is after her 3rd treatment, and I asked her one day, I was like, how are your eyes feeling? And she literally had to stop and think about it. That's how you know your dry eye patients are doing well, when they aren't thinking about their eyes. And so I love that. So treatment settings are going to depend on, you know, what kind of rosacea they have, and then what kind of skin type they have, right? So treating deep and large to smaller and more superficial. So we have to treat deep first. And so on her, I did a medium to deep depth at 590, triple pulse, 3, you know, millisecond, 30 millisecond, 20 joules per centimeter squared. And then I did a second pass that was more shallow. That's a more aggressive setting. So the more shallow you get in the skin, the more aggressive that is. And so first pass, second pass, and then 3rd pass, I did the Toyo settings. And again, I had just her little sticky shields on. But if you're going to do eyelids, then make sure you've got your laser grade corneal shields. And when I do those, I switch to the small rectangle light pass, the little light crystal, that's the smaller one. And it's going to look just like your menu that you see over there. Stay 2 millimeters away from the lash line. You do not want to roast their eyelashes and singe an eyelash. That is no good. And you're going to do a total of 24 pulses. So you're going to do 3 on the top, 3 underneath, and then 3 on the top, 3 underneath, and then you're going to do a second pass of that for a total of 24 pulses. That is my recipe. And then this was another patient that after 3 treatments also had Meibomian Gland Dysfunction secondary to his ocular rosacea. And I did a very similar recipe with him. And he was a very similar skin type to her. This is a little, just a little solar lentigine that this patient didn't like. So those I treat with my 6 millimeter circle, and I go to the pigment lesion menu. She's a type 2 skin type. I put in lentigines. It's a lighter, it's epidermal. There's that 515. This is what it told me to do. And I practiced with this, and it works great. Clinical endpoint is the pigment will immediately turn darker salmon colored, and you know that you've gotten that. If you want to do some telangiectatic vessels, you know, like scroll down here, you can see a few little telangiectatic vessels. If she wanted those and they were up by her, closer to her eye probably, then we would treat those by using the vascular filter. And again, it gives us those settings, but you know that you got that because the vessel will immediately vaporize. But you need to look for backfill. If you do it and it immediately fills back up, then you've got a vessel that you're going to have to, that's a feeder vessel that you're going to have to go treat. So this is post IPL, and this was a patient that we had done twice. We did not treat lids. He was not a big fan. He had suffered with chronic chalazia and hordeolum. You can see that he's got notching, he's got those telangiectatic vessels, but look at those beautiful beads of olive oil after just 2 sessions. And he was one of my first patients. So I've seen him for 2.5 years now. And so we do 1 maintenance session with him every 6 months. Knock on wood, he has not had a chalazia or hordeola since and is much more comfortable. If a patient has dry eye disease and Meibomian gland dysfunction, but no facial rosacea, you can also do a photofacial with it, and lots of my patients want that. And this is what the settings look like for a type 3 patient to do a photofacial, especially if they've got shallow spots. Let's see what time it is. Good. Make sure we have time for questions. So you can treat chalazia with this, which I do a lot of, incision-free, injection-free, scar-free. And Dr. Perryman is really the one that has pioneered this, but I have treated multiple patients with acute and chronic chalazia that were less than thrilled with me doing an incision and curettage, and they have done beautifully. And so to do that, I will stack the pulses basically. I do, and this was a patient that I treated, and that was a really big lesion that he had. And so I do Perryman's protocol, and then I do 2 to 3 extra pulses right on top of that lesion with the small light guide, and these patients do beautifully. So how does IPL like actually work? What is intense pulse light really doing to the tissue? So go back to our acronym of BESTO. So bugs, right? So staph and Demodex. Remember, Demodex were photosanitization. Think of it that way, because we're actually barbecuing the little exoskeletons. They literally can't live in the presence of treating IPL. We've got enzymes and inflammation. So we're decreasing the amount of inflammation and enzymes, and stasis and temperature and obstruction. So we're photocoagulation. We've got photoimmunomodulation happening, photomodulation, and photothermolysis. That's how IPL actually works. It's doing all of those things. This is my sunscreen that I use. I make sure that the patient leaves with that. So your algorithm could look something like this. This looks really wordy. I'll let you guys dive into that later. But the key to anything is to just start somewhere. If you've got somebody in your area that's doing this, I've got docs that now refer to me, and if you've got it in your clinic, awesome. If you want to get it in your clinic, then this is the one thing that has really stood out to me in my dry eye clinic as far as having a tool to help patients, because there is no magic silver bullet, but patients feel better with this, and you're going to see some data that will come out and get published later, probably maybe next year, on, and I've seen this anecdotally in my own clinic. Their inflammatory improves, their tear lab osmolarity improves, their vision improves, and their symptoms improve. And so, develop your systems, involve your team around you. Don't try to do this in a vacuum. There's no magic silver bullet, but these patients, and this is so within optometry's scope of practice. This we should own. And so I want optometrists across the country to be doing this, and referring back and forth to derm, referring back and forth to PCPs, referring back and forth to each other, referring back and forth to their MDs that don't want to treat dry eye. Our profession and our patients really need us to be able to do this. So I would love to answer questions. And so I am going to stop sharing my screen so I can actually see your questions.
Awesome. So thank you, Dr. McGee. As you're setting up, I'll just do a quick reminder. If you have any questions, please type it in your question panel. And I see that we have several questions here. So as you're setting up, I'll read the first question I have here real quick. A question from Dr. Elizabeth Wiles. Can you have the patient take an OTC, aka Advil, to help with the discomfort?
I mean, you probably could. I haven't found that patients honestly really need it. If you walk them through it and you go slow, but I don't know why you couldn't do that. It's funny, it's usually my dudes that have more trouble than my women.
Got it. So the next question we have here is, how do you determine if a patient is a good candidate for IPL treatments?
Great question. So if they have any of those telangiectatic vessels crawling over their eyelids that you see behind the slit lamp, then we talk about IPL. And it depends on where they are in their process, but I start talking about it right from the beginning so that I have planted that seed. We might not go there for first line of treatment, but it's already talked about and it's in our arsenal so that if we need it down the road. So if anyone that's a candidate that has those telangiectatic vessels, then we are talking about it. And then, you know, something else that's really important about this treatment is it's drug-free and it's drop-free. So there's lots of patients that don't want to take drops, that can't take drops, that, you know, don't want to take an oral medication or et cetera. And so this is a drop-free, drug-free option for those patients. And that really can resonate with that patient population as well.
Got it. Next question we have, is there any age contraindications?
Good question. So the age, you know, and this is already off label in the US. So I would defer to Lumenis on that, but I don't treat anybody. I think the youngest person I've treated was 22, but they use this to treat kids with acne and they're in high school. So I would talk to your Lumenis rep and ask that question, but I have not gone below the age of 22.
Okay, next question we have. How does IPL and RF differ in treating the meibomian glands?
Good question. So IPL targets the blood vessels and inflammation. So again, think BSTO. So IPL will treat all of those. The one that it doesn't treat quite to the extra star is the heating part. But radiofrequency, because of the way that it's working, and it's actually heating the dermal layers of the skin. So typically you want to heat that to 42 degrees Celsius to be able to target collagen stimulation. But there are people that are using it to treat meibomian glands through the heat process. And of course, with radiofrequency, you cannot use any kind of metal on the body or you will cause a spark and a burn. So you have to have plastic corneal shields in that case to be able to treat the glands. And it's more of a thermal pulsation act when you're using radiofrequency to treat the meibomian glands. So it's actually using heat, whereas IPL is using light to target oxyhemoglobin and causing photoimmunomodulation.
Perfect. We have a whole lot of questions here, so I'm selecting them based on as they come in. So perfect. One question that came in is, how much do you charge? I mean, if you could share some range with us. You know.
Absolutely. So if you look nationally, most people are going to charge anywhere from $300 to $400 per session. So in my clinic in Oklahoma, I charge $1,200 for a series of 4. If the patient chooses to pay it out, which I don't like them to do because I want them to get the full treatment, then they don't get that little extra discount, and then it's $1,600 for the whole series. So, and that's pretty well within the national range of docs that I've talked to across the country. So $1,200 to $1,600 for the whole series of 4. And then for my maintenance treatments, I charge $250 for those maintenance treatments. Now, if I have somebody that has like a lot of pigment around here or around here that they want treated and we're spot treating, I do charge extra for that because it does take more chair time, and I'm switching out filters and I'm switching out the crystal. And so if they have a lot, if they have 1 or 2, that, you know, is included. But if they have a lot and we're doing more time, you know, charge for your time. But on average, around $1,200 for a patient.
Perfect. Next question we have, I haven't seen this question come in before, so I'll ask it. Okay. Would you treat people who are albinos?
Well, they have no pigment. That's a good question. I've never been asked. I don't know why not, because they're basically a skin type 0, right? So I don't see why you couldn't. I'd love to hear somebody else's thoughts, but that's my first thought, is because we're targeting oxyhemoglobin with this and they have 0 pigment, that they would be the safest patient to treat.
Perfect. Next question we have is, for men with facial rosacea that extends into the beard, is it possible to treat the rosacea without permanent hair loss?
Not really. And so but the interesting thing is, and I have a patient right now that I'm actually treating that has a pretty heavy beard, but even just treating the area, basically from here to here, he's done remarkably well. And so I also have another patient, the patient that was in the slide deck, the second patient is male, and he was not partial to his beard. And so we treated, you don't want to treat hair, but we treated clean shaven over the top of it, and he was quite happy with that. And, he didn't have a lot of hair loss, but they still get really good results, even when you treat above the beard line.
Got it. Next question we have, do you have a dry eye coordinator talking to patients after you recommend your treatments?
I actually do. And I'm training her right now, actually. So I have had that in the past. And when you have that in your clinic, it is a very beautiful thing. And because there is a lot of pieces to this and patients have a lot of questions, anytime that you can delegate things that you don't have to do, then delegate it. You're the physician, you prescribe what the patient needs, but the nitty-gritty details of, what you should do pre-procedure, how much it costs, why we're doing this, etc., that can absolutely be done by a dry eye coordinator. And I think if you have that in your clinic or someone that's really interested in dry eye, utilize that person. They are a huge benefit and a huge asset to your dry eye clinic.
And I'll cover the last question here. Any tips on getting other doctors to refer to you? Do you reach out to local OMDs or family docs in your area?
So yes, build your network, and I would start with people that you already have relationships with. Maybe it's your OMD that you refer cataract patients to that doesn't know that you have this. So that's a great place to start. My oculoplastic surgeon refers people over. I have gone to my rheumatologist and talked to them that has a big group in our area. Derm, I haven't gone and talked to, but that's on my list. And then I do have ODs that also refer. So absolutely, don't be a big, well-kept secret for dry eye patients. And I mean, you guys all know this. You just make sure that the patient goes back to their doctor for their general care or their glasses or contact lenses, etc., that you're just doing their dry eye piece, and then that they get their normal care back with their physician.
With that in mind, it looks like we covered majority of our questions. Again, thank you, everyone. Thank you, Dr. McGee. We appreciate you being here. If you guys have any other questions, it looks like Dr. McGee had given her email address in her final slide. And you could also email us at lumenis.vision@lumenis.com, or you can reach out to ASOS as well. Again, thank you for joining us today, and we will see you next time in our next series.
Awesome. Thanks, Barney. Thanks, guys, for joining. Please email if you have any questions. Have a great evening.
Bye, everyone.